Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with Josh. How are you doing today?
Good, Dennis. How are you?
I'm doing well. So today's topic is labs in the austere environment. But before we begin, would you mind doing just a quick introduction of yourself?
Yeah, I'm Josh. I'm an Army emergency medicine and critical care medicine doc. I'm fortunate to be stationed in Colorado Springs, where I get to work at a civilian level 1 trauma center in the ICU as a half-time employee on the Army's dime.
Nice. It's a good job when you can get it, right?
It works out.
So especially when you're getting into labs, when you're thinking about extended care, which obviously is very different than what we've been doing the last few trips, labs start coming up. Okay. And I think medics, we get advice, we get gear, with not a lot of training to go with it. And so that's what I would kind of like to walk through is kind of what labs are important, when they're important to take, and what do I do with this information going forward. So maybe let's start with kind of the trauma stuff, because those who need pretty timely information. Obviously, we're not doing blood draws during March sequence, but I would imagine soon after you would want to start at least drawing labs. So like when in the ER, when do you guys start drawing labs?
If patients haven't come in via EMS with blood already drawn, then traditionally we'll do our primary survey, our ABCs in the ER, address immediate life threats, and then draw blood at that time, send it off to the lab, and within 3 to 5 minutes get a blood gas result and ABG results. And then the rest of the things will be cooking in the next 20 to 30 minutes while you're doing your secondary survey and your imaging.
Okay. So obviously, ER, especially on a trauma team, you have quite a few people kind of running, doing very specific jobs. I have like myself and maybe one other guy. In that March, would I wait till we're done with the March sequence and then start thinking about it? Or like when would be a reasonable stop point or a time under this time you need to start drawing labs?
I would think in that situation, you kind of do all the things that immediately come to mind, right? So probably do your March, and then if you have access to an ultrasound, do your fast, and then do your head-to-toe primary and address everything you find. And then you're like, well, what do I do now? And that's when you can draw some blood and get cooking on it while the patient can do without you for a period of 5 to 15 minutes.
Okay. Now, a lot of the labs, it seems like they come from like arterial sticks. Can I do like a venous stick? Because I'm already getting venous access for my resuscitation fluid and narcotics, etc. Can I just use that blood instead?
Yeah, the only lab that you need arterial access for is an arterial blood gas, the specific ABG. Everything else can be venous. You should draw 10 cc's of blood from that syringe and waste it before you draw blood to be tested. Otherwise, you get inaccurate results.
Is that just from whatever fluids I was pushing?
Yeah, and like stasis and fluids, yeah.
Okay. Now those cartridges, and when I'm thinking cartridges, I'm thinking like the iStat. I'm sure there's a myriad of other devices out there that'll do it, but that's the one at least that we have available. Those take like 1 cc at a time. So I draw up a 10 cc syringe. That's a little bit of fine pushing. So I would imagine some practice is in order.
Yeah, I'm not a lab weenie, right? So you'd have to find a kilo or some sort of lab weenie to actually go through the mechanics of how you get an accurate iStat reading. That's unfortunately not my purview, but I think it's like a 5 to 15 minute class is all it needs.
So kind of practicality of it. Okay. As soon as March is done, as soon as your secondary assessments, you've kind of treated life threats, you're at that kind of natural pause in the sequence. Now is probably a good time to go ahead and get your at least initial lab values, set up that baseline. What specific labs are you interested in that early in the treatment?
So I'd say all patients, you should get a hemoglobin and hematocrit, which is the standard ISTAT cartridge. You should get some electrolytes and kidney function, which is your metabolic panel, your Kim7. And trauma patients, you should get an INR as another cartridge. And then sick patients who are unstable, actively bleeding, I would want an ABG on as soon as possible to give me an idea of their base deficit or how much lactate they're collecting through lack of oxygen delivery to the tissues.
Okay. Which of those are you going to pay attention to first?
The ABG is your most immediately actionable test. And you will see therapists in the hospital will classically get your radial stick, but that can be a pretty small artery. And I would say if you're in the field with a sick patient in the dirt, I would just go for femoral access. You can palpate that femoral pulse. It's going to be more durable than the radial pulse. It's a bigger vessel.
Okay. Is that something I can just put a catheter in like a PRN adapter, or is this a new stick each and every time?
Unless you came out with an arterial line kit, I would just do a new stick each and every time. And then you have to hold pressure for 5 to 10 minutes afterwards on the artery because it's a big one.
Okay. How frequently are you doing these arterial sticks? Because we're really good at turning tissue into hamburger.
Yeah. So in my mind, there are probably 3 patients who I wanted ABG on. One is acutely critically ill. It's established their acid-base status early. One is a ventilated patient who is not triggering the ventilator, so not overbreathing, because I want to know why they're not overbreathing. Am I hyperventilating them? Are they over-sedated so they don't have respiratory drive, or have they had a devastating brain injury that's taken away the respiratory drive? And then otherwise, very severe sick lungs with ARDS, I want to check their actual arterial oxygenation. So I think in the field, you don't need to do routine ABGs. I would think just immediate point of injury and then kind of guide resuscitation based on vital signs and how they're responding to blood.
Okay. Like just the vent management piece. I mean, I'm using my SpO2 monitor. I'm using my end-tidal CO2 monitor. Obviously blood pressure, the rest of the vital signs. But when it comes to vent management, like, am I just kind of going off those non-invasive measurements early, and then, when I get a chance, get a blood draw and then kind of confirm? Or because these things can essentially argue with each other. One is saying, like, he's end-tidal is very low. You draw the blood, it could say his blood end-tidal or his PaCO2 is very high.
If they're not delivering oxygen.
Yeah,
the PaCO2 is going to be more accurate. Or PV, if you just get a venous blood gas, if you don't want to do an arterial stick, is also just fine. You're injured combat soldier.
Okay. So the venous side, is that something that, like, the machine can automatically calculate, and is there error in that?
Yeah, the only time a venous CO2 would not correlate well with an arterial CO2 is in like very severe COPD. There's PCO2 gas exchange problems, but your average Joe on the battlefield is not going to have that problem. So a venous, for the purposes of CO2, a venous is just as good.
And at least from what I remember, the ISTAT is capable of just doing that kind of conversion on its own. You just got to tell it what kind of sample. Yeah, you just have to tell it what kind of sample it is, and then it runs it. So going away from maybe your ABGs, because I imagine I'm using that more for my vent management, okay? Especially fairly early in trauma, they're going to be acidotic, right? So I'm not going to just start sending, vial after vial of sodium bicarb to fix their acidosis when the obvious problem is they need blood. So I would, and I could 100% be wrong, I would kind of ignore necessarily what their pH is until I've actually got a good blood pressure. We've got good urine output, like they seem like they're resuscitated. And then, okay, maybe we need to start fine tuning things. Does that sound reasonable?
Yeah, it can give you an immediate sense of how sick they are. If somebody comes in normotensive but actively bleeding, if they have a pretty severe base deficit or metabolic acidosis, that can clue you in before their vital signs start to change. They're compensated but still very sick.
Whether they're metabolic or respiratory compensating? Okay.
Yeah.
So what about this lactate? So, I'm at Soma or something, and, provider is presenting, and especially with trauma, they're always bringing up lactate. Why?
Yeah. Lactate is a useful marker of resuscitation. It's a marker of absence of tissue oxygen delivery. So when your body's going through its chemical cycles using oxygen, if it doesn't have oxygen, it creates lactate.
Which absolutely makes physiologic sense, but in the sense of trauma, their catecholamines are coursing through their veins, like they've just been in a fight or flight type situation. I would imagine that is going to throw it off compared to somebody resting and you take their lactate.
Yeah, so the guy who's just been sprinting through a field to get to a house is going to have an elevated lactate at baseline, right? But if he's not sick, if he sprinted to a house and then sits and recovers for a few minutes, that lactate will clear. Whereas somebody who has ongoing low tissue oxygen delivery because they're bleeding, they don't have oxygen to deliver to the tissues, will have an elevated lactate that doesn't clear.
Okay, so lactate will shift fairly rapidly.
Yeah, your body, it's a food for your muscles, and so your muscles will chew it up. And then if it's not being regenerated because you have fine oxygen delivery, then it won't re-elevate.
Okay. So as far as lactate, when should I start caring?
I would care. As soon as you get one, if it's elevated, you should care about that.
But I mean, like, what's elevated? What's elevated for a trauma patient?
Yeah, higher than 2 would be normal. Would be abnormal. Sorry, 2 would be your upper limit of normal. But I get scared when it gets above 6 to 8. Scared is the wrong word. I start to worry and notice an acutely sick patient. Like, this patient needs to be resuscitated.
Okay. Now, can you be resuscitated and still have an elevated lactate? And it's one of those things like, let's give them another 30 minutes kind of thing.
Yeah, we'll take time to equilibrate.
Okay. So I'm giving him fresh whole blood. I would imagine that's going to dilute your lactate and maybe artificially bring it down, or is that not true?
I don't think it works like that. No, I think that it will go away as it's cleared, as the oxygen gets delivered.
Okay.
The body chews it up and it's not regenerated.
Okay. So I guess how do I reconcile? I'm assuming low blood pressure, elevated lactate. As I'm giving this guy blood, his blood pressure is kind of coming up. How do I reconcile? He's got a good blood pressure, but an elevated lactate. Does that mean I still need to resuscitate, or like, what do I do with that?
In the field setting, you probably want to conserve your resources. And so if you've restored hemodynamic stability and you don't think the patient's actively bleeding, I would not target normal. I would say normal is better than you need. So I'd shoot for normal-ish vital signs and not worry about the lactate in the patient you've resuscitated back to reasonable vital signs.
Okay. And I'm using more of the lactate to kind of clue me in that, hey, he's continuing to bleed, or, a new bleed has opened up kind of thing. Is that right?
Yeah, he's not back to normal.
Okay. All right. So the problem didn't go away. All right. Very good. One of the other things you mentioned was like your hemoglobin hematocrit. How do I use this?
So I think it's helpful as a baseline, right? You get it as soon as you can after the trauma. And so, let's say you get hemoglobin an hour after something happened, that will be a little lower than his normal baseline, but not his baseline, but also won't accurately reflect where he's at when you drew the blood, because the hemoglobin in the blood will take time to re-equilibrate as he loses red cells, and then fluid will come in from the third spaces to refill the vasculature. So you get an inappropriately high hemoglobin shortly after trauma, but it's more useful as a trend. So you establish a baseline and then you trend it every 4 to 6 hours to see if someone is actively bleeding. You watch it drop if someone is bleeding.
Okay.
That makes sense.
Now I've heard using hemoglobin as a trigger to give blood. I've heard very low numbers, like 6. I've also heard numbers like 10, which is barely on the low side of normal, or just below the low side of normal. What is kind of the latest consensus?
Those are not useful in patients who are in active hemorrhagic shock, right? You target normal vital signs. You don't target a normal hemoglobin, you just target normal vital signs. And I would say there is no specific hemoglobin target in the actively bleeding patient. You're just shooting for normal tension, preservation of end organ perfusion. There was just released so that normally in almost every patient in the ICU who's not actively bleeding, your hemoglobin target is 7, right? I'm going to transfuse for below 7. And as compared to 10 is generally what they do. 7 is as good as 10 in terms of mortality and long-term outcomes. The only difference is severe TBI patients probably do better with the hemoglobin of 10. That's the most recent data. So if you're sitting on somebody for 48 to 72 hours with multi-system trauma who also has a TBI, after the immediate resuscitation, then targeting hemoglobin of 10 as opposed to lower threshold is probably better for them.
Okay.
I say that in English.
Yep, I understood. So I guess just thinking about it, like resuscitation-wise, at least when it comes to hemoglobin hematocrit, like this is a later problem. Like right now, I'm just tracking, blood pressure, heart rate, urine output, and just running with that, and then later I'll worry about hemoglobin hematocrit.
Yeah,
at least for
it's
a bleeding
PFC problem.
Yeah.
But it's not an immediate TC3 problem.
Okay. Now, what about things like burns or things other than penetrations, bleeding? Are hemoglobin hematocrit useful in these types of patients?
If you're training an H&H on a patient with a large burn, who you're actively resuscitating with large quantities of crystalloid, you're going to watch the hemoglobin drop, and that will be dilutional. So then you'll have to be on the lookout for, are they bleeding or is it just a dilutional drop in hemoglobin? I gave them a liter of crystalloid over the last 7 to 8 hours. Their hemoglobin dropped a point. That's probably from the crystalloid. So use it as a trend.
Can I use this to adjust treatment, or is it just something that I'm trending because?
Trending because you can.
Because I can. I'm going to use these cartridges, right? Is it something that I can use it for to adjust treatment?
So the burn resuscitation for major burn lasts about 48 hours, right? So if you're now 72 hours out and you're no longer actively resuscitating, it can be useful as a trend, right? Presumably a combat burn is not simply a burn, it's also multi-system trauma. If they had some internal hemorrhage, you can use the hemoglobin to see if they're bleeding before you catch that in the vital signs.
Okay. All right. Very good. Very good. Electrolytes. So the electrolytes that are hottest right now, potassium and especially calcium. So, when I say it, I shiver, right? So, one, are we actually trending these things, or is this like very specific use, or are there other electrolytes I need to be more cognizant of?
Depends on the patient, right? A brain injury patient, you want to keep their sodium a little bit higher, raising out the brain. So you give them lactate ringers as a crystalloid solution, they'll generally do worse than patients who get saline. And you can use because the sodium content is lower, so you can watch somebody's sodium. Generally in the ICU, a severe brain injury, you'll target a sodium of 145 to 155, which is 10 to 15 points higher than normal to keep the brain more raisined. I know you've talked a lot about crush injuries and watching the potassium. I would say that in general, if I don't have a reason to, I will trend electrolytes daily, if not less, in my ICU patients. But in the acute phase after a crush or a burn or tissue destruction, you want to watch their kidney function and, as a result of that, their potassium a little more closely. I would say every 6 to 24 hours if you can.
Okay. And it's just more trending it as it should be clearing. If it's not clearing, kind of why not?
Yeah, so their kidney function is another marker of your resuscitation, right? The kidneys can take a hit as a result of hypotension. And then most of the time in your active duty population, they'll come back if the patient is adequately resuscitated. But sometimes they won't. And so you can see inadequate urine output as an initial sign of AKI, acute kidney injury. The creatinine will be a lagging indicator of acute kidney injury. And the potassium will go up as the creatinine goes up if they're continuing to have tissue destruction or if they're getting fed, because the kidneys won't be clearing.
Like especially with crush or, like a long tourniquet conversion or a hypoperfused state for an extended period of time, like you can have an elevated potassium and I would imagine elevated creatinine as well. But how do I'm measuring their urine output, right? I would imagine as long as my urine output is between 30 to 50 or 0.3 cc's per kilogram per hour or 0.5 cc's per kilogram per hour, a normal range, like, is the CK really helping me or is it just another number to trend?
Yeah. So CK will go up like this within 24 hours and then plateau for like 48 to 96 hours. The CK can stay stable if there's no ongoing tissue destruction. And so if you have the ability, you can check a CK within 24 hours and then check it again 6 to 10 hours after that. And if it's continuing to rise, that clues you in that there's ongoing tissue destruction, versus if it stays stable, then you know that your tissue destruction is addressed. So that can give you an indication in like limb ischemia from a tourniquet or a crush injury that you need to amputate. You need to get rid of that dead tissue because it's continuing to release toxins.
Okay.
If the CK continues to climb.
Okay. Absolutely. Kind of that life over limb type decision.
Yeah, if for whatever reason you have to leave a tourniquet on after 24 hours, depending on how long you're going to have to keep that patient, it may be more reasonable to amputate than to try a tourniquet conversion, because you're going to release a lot of toxins and there's going to be ongoing toxin release from that tissue.
Being a fairly, well, I'm not a new medic, but coming into this kind of newer world, extended care, getting new gear for labs. If there was something you really wanted me to focus on, right? I guess what would it be so that I can better facilitate a patient, bringing a patient to, a higher level of care when it comes to labs?
Yeah. As I think about what we've talked about, it's probably a little confusing, right, for the medic who's never thought about this stuff. We haven't established any, like, these are the normal numbers and these are the numbers that you get when you do each test. And it's probably a lot to take in, and without looking at it on paper, I'm not sure this would be beneficial. And so, we've survived for 20 plus years of OIF and OEF and whatever they're calling the new ones without labs on the field. If people are truly doing prolonged field care, they probably should be monitoring hemoglobin, electrolytes, and getting blood gases on ventilated patients. But there has to be some rigorous standardized curriculum to learn what's normal, and then to quickly recognize what's normal when you have a sheet of numbers in front of you. And so rather than go cowboy and start checking INRs on all of your patients whenever you get the urge, I would say spend time to look at a bunch of sheets of numbers and learn what is normal, and then get an idea.
Cheat sheets, like everybody makes cheat sheets, and I think we went over at least the basic ones that you should be drawing. It's too easy to find out, normal, abnormal, they're within this range in male, female, child, arterial, venous, whatever conditions is going to change that standard. And put that on a 3x5 card, have it laminated, stick it right on top of the iStat so you can't lose it, right? But what I'm a little bit concerned about is, we get a new piece of gear, we jump on the bandwagon, and this is the best thing ever. It'll do all my thinking for me. And, I'll just start chasing this machine around, the numbers on it and just doing stuff. And I think what's also really important is how do I take this new data and put it into context with my patient, how to put it into context with the other vital signs that we're getting, and maybe understanding I may or may not lean more heavier on labs or what my vital signs are telling me as far as treatments, if that makes sense.
Yeah. Yeah. So the first thing I do when I come in the mornings is look at vital signs and labs. And then I go see my patients with an idea of what to expect, right? And so if somebody has suffered from an acute kidney injury, an elevated creatinine since the last time I checked, with oliguria, with low urine output charted, that gives me a different sort of differential approach as opposed to somebody who continues to make a reasonable amount of urine, but their kidney function is worsening. Does that patient have an ischemic injury, but his kidneys are likely to recover versus a patient who's oliguric? Is he going to respond to volume, or have his kidneys been punched and given up? And if I give him more volume, that's just going to go to his third space and to his lungs. That's a combination of like.
It can be it can get really complicated. I've had like 6 months of training, so let's keep this in mind, right? It turns out like there are just people out there in the world that just think about this stuff and they use these numbers daily. I think it would be really smart to probably call somebody, even if you don't necessarily understand what to do. Like they can do that for you. They do this all the time.
Help. Yeah, please ask for help.
Yeah. But even that, I mean, there's all kinds of context and all kinds of different stuff. But if you don't know, at least reach out with the data you've gathered and let somebody else kind of take that mental load off. Okay. When it comes to drawing labs or interpreting labs, etc., do you have any other advice for somebody, kind of coming into this? Hey, what do you want me to do as a medic? Like, what is it you want from me?
Yeah. So let's say a multi-system trauma patient with a few different injuries, and you're checking labs on day 3, and the patient has developed new shock. So you're doing your thing on one patient, and then your buddy at the bedside is like, hey, this patient is just getting worse. You can look at them and you can have like an immediate differential for what might be going on, and sending a hemoglobin and an INR and getting a blood gas can be part of that. And in the immediate like new shock patient, you probably want an ultrasound to look for tamponade or pneumothorax that might be causing tension. But if you've ruled out those things, then the hemoglobin and the INR can help you. Does that kind of answer your question? Like how?
Yeah, it definitely does. I think it's one of those things that, like any new toy, we have to like learn how to incorporate this into our just normal kind of practice. Like you mentioned, like you're an ER doc, you're an ICU doc. This kind of goes with the job, right? When you first started, you were taking labs.
That's what we do.
It's definitely, it's not the case with us. So, guys love gear. And as soon as I get a new number, like I am so happy that I have a new number that I can just think about. But realistically, understanding how does this incorporate into the entire picture, I think is one of those things that we just need. We need help, we need experience, we need somebody to come teach us and then get practice doing it.
Yeah, it's new data, but not necessarily life-changing. I would make a habit of calling the advisor line every morning, or maybe twice a day, and just kind of do rounds. Like, this is the newest data that I have. Can you help me think through this patient? If you have that opportunity.
Yeah. If you're able to, as I would say, call them as often as you want to, because
so we're not doing anything else.
Yeah, they're not doing nothing. They'll get somebody on the line, right? Well, awesome. Is there any other advice you got?
No, I hope that was helpful. That was probably confusing mixture of stuff. Maybe an introduction. Don't tell anybody at the CBT guidelines that I told them to amputate a leg after a tournament's been off for 12 hours.
That went live, but I think you're absolutely right. Like, we need to have like a concerted effort to incorporate this into our normal flow. And I think all of these things will make a lot more sense. Because, I mean, you're getting cartridges that are like pre-programmed to just throw numbers at you. They mean something to somebody, but it doesn't necessarily mean anything to me. And when you put it in the Google machine, it can tell you all kinds of different directions to take your patient and what they need. And just like, end-tidal CO2 or SpO2 or any other number, normal is not necessarily what you want for your patient at that moment in time. And just because you make it normal doesn't mean you fixed your patient.
Agreed.
Perfect. Well, thank you, Josh. I really appreciate it.
Yeah, thanks for having me, Dennis. Appreciate it.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.